Thank you, sir, for giving me this opportunity. And today I'll be discussing about the ideal sequencing in metastatic renal cell cancer. My previous speaker, Dr. Bajaj, has already covered the first line therapy, and I hope my slides are visible and I am audible.
Yes, yes, sir.
Yeah, thank you. So, why we are discussing this? Because attrition from the first line to the next line of therapy, according to IMDC data, 50% of the patient will require second line therapy. Then 24% will require third line therapy, and about 8% will require fourth line therapy. They might be fit enough to require those 8% might be fit enough to receive a fourth line therapy. So this 50 and 24%, these are major chunk of the patients which we get in our real time practice and in the real world data. So we need to know how to go about it. As so these are the preferred agents: cabozantinib, everolimus, lenva with evro, lenva with pembro, nivolumab, nivo with ep, tivozinib, and this telaglenastat. It's a newer drug. So whenever the patient has received IO therapy, what is to be done? So this was the study, phase 2 keynote study of lenvatinib plus pembrolizumab after progression on the previous IO therapy, and the patient had responses to lenva plus pembro. You can see about 55% of the patient did have PR when they received this type of therapy. Although it's a phase 2 data, we need to remember that whenever we request the nuclear within doctors to apply iRECIST criteria, since we are using immunotherapeutic agent. So when we have post VEGF TKI, what we have the option of cabozantinib. This was the Meteor study in which cabozantinib was compared to everolimus, and we can see that the overall survival is better with cabozantinib compared to everolimus, and the side effect in 70% of the patients had of cabozantinib patient had grade 3 or 4 side effects versus 60% in everolimus arm, and the most common being hypertension, diarrhea, fatigue, anemia, hyperglycemia, and hypomagnesemia. So this was the data of PFS and OS. If we see, the blue line is for cabozantinib, and the graphs are separated significantly from everolimus, and similarly for the OS. So median PFS was 7.4 months with cabozantinib versus 3.8 with everolimus, and the rate of progression or death was 42% lower with cabozantinib than with everolimus. Another drug after TKI is nivolumab. This is checkmate 025. Again, nivolumab was compared to everolimus, and the median PFS was 4.6 months versus 4.4 with hazard ratio of 0.8. However, the confidence interval, if you see, had crossed 1. It was 0.75 versus 1 with non-significant p-value. Another drug which is available is lenvatinib plus everolimus. This combination is also being used commonly in second line, even in third line. So this lenvatinib 14 mg plus everolimus 5 mg versus lenvatinib 18 mg versus 5 mg of everolimus. It's a phase 2 trial in which, if we see that lenvatinib 18 mg, which is blue color, versus lenvatinib 14 mg, the blue graph 18 mg is showing better results. Similarly, the OS is better when 18 mg the starting doses are given along with everolimus. What I feel in our clinical practice, everolimus is the difficult drug to manage because of this mucositis. Lenvatinib does have its own side effects, class effects of hypertension and weakness and fatigue, but the everolimus, I think, is the rate limiting drug which has to be managed tactfully. Another drug is tivozanib. It's a phase 3 trial of tivozanib versus sorafenib in advanced RCC after PD-1 or PD-L1 inhibitors and TKI therapy. It was an open label study. Tivozanib 1.5 mg per OD once daily, 3 weeks on, 1 week off, compared to sorafenib 400 mg every day. And again, the blue graph is of the tivozanib, and it's showing that hazard ratio is 0.73 with confidence interval being less than 1 and p-value of 0.16. So that's why it has been now included in the NCCN guidelines as shown by the previous speaker also. The overall best response was, as expected, is PR in about 31%, in about 18% of the patients versus 8% of sorafenib. The median duration of responses has not been reached for this drug. However, with sorafenib, it is 5.7. Another drug is glutaminase inhibition with telaglenestat in RCC. So in preclinical study, the combination of this drug along with the signal transduction inhibitor everolimus has shown it inhibits the glucose and glutamine pathways, has synergistic anti-proliferative activity and enhanced anti-tumor activity. So this drug in the Entrata trial showed that when combined with everolimus, it has shown a median PFS of 3.8 versus 1.9 when alone everolimus was used, with hazard ratio of 0.64. This drug has also been combined with cabozantinib. However, with cabozantinib, it did not meet its primary endpoint. We can see the graphs are almost overlapping each other, and there was not much of a benefit of adding this drug along with cabozantinib. Another drug is belzutifan. It's a HIF2 alpha inhibitor. As we know, HIF2 is one of the pathways because of which the cancer cells progresses. So when this drug belzutifan 120 mg orally once a day is given, we can see where the waterfall graph 64% of the patient had experienced a tumor shrinkage. Another therapy is CAR T cell therapy in RCC. It's just in phase 1 trial and still under experimental arm. So how to chart the way out? So ideal endpoints in metastatic disease, we need overall survival. We need to add years to the life. However, we need a good quality of life also. That's why we need to add life to those years. We need to take care of the quality of life, definitely. So selecting the salvage therapy for patient with high volume and rapidly progressive disease on prior VEGF, cabozantinib versus everolimus, it has shown that cabozantinib is beneficial. Lenva plus everolimus versus everolimus alone, again, Lenva has shown a benefit, and nivolumab with everolimus down the line, it shows benefit. This trial data had not shown much of a benefit. The confidence interval was again crossing the 1. So sequencing, if one has given IO in the initial therapy, nivo plus EP, then second line is cabozantinib, and if patient progresses on that, then Lenva plus everolimus followed by axitinib or tivozantinib or axitinib alone where lenvatinib is not available. Although it shows that everolimus single agent can be used, but I don't think any of the trials have shown much of a benefit of using single agent everolimus. Sequencing, if we have used for initially TKI, then we can use IO therapy, IO or axitinib with pembrolizumab. If the patient progresses, then Lenva with everolimus or axitinib. And then in the third line, we can use axitinib with tivozantinib or everolimus. And again, in sequencing, if we see, if we have used initially Lenva plus pembro, then cabozantinib, followed by ipilimumab plus nivolumab, followed by axitinib. So all this data shows that if you have used A therapy, then you can use B followed by C. If you have used B initially, then A followed by C. So what we need to, various thoughts, as I am telling you, EP plus Nivo followed by Nivo, if has progression, then add EP again, add TKI, only TKI. VEGF post IO are active as per data post first line. There are no randomized trial. Lenva plus everolimus, hazard ratio of 1.14 in the clear trial. It had shown that sunitinib is better. Stoppage of IO followed by TKI to remember long half-life of IO. So the clinical dilemma, what we face in the OPD is that what is the performance status, what is the general condition of the patient, what is the volume of disease, how much symptomatic is he, what was the tolerance to the first line, durability of the therapy, how long the patient tolerated or continued or benefited from the previous therapy, mode of administration, patient doesn't want to come regularly now, he is fed up of coming, so oral therapy compliance may be better. Financial toxicity is definitely one of the factors, and absence of any biomarkers. We are not sure which drug is going to help him doing better responses. So absence of biomarkers is one of the factors which we neglect, but in the back of the mind, we know that we don't have any biomarkers to decide on the therapy. So with this, thank you so much, and I handle back to the organization.